Hi, everybody, and welcome to today's webinar on health service delivery before and after the pandemic. This is episode 5 of the webinar series brought to you by the European Health Management Association on health management in action, fostering health systems resilience. And this webinar series is co-funded by the EU for Health program of the European Union. So we thank them for their support. If I can have the next slide. I'm George Valiotis. I'm the Executive Director here at EMA, and I'll be moderating today. I'll tell you briefly about EMA. I think a lot of you in the room know who we are, but our vision is excellent health management for a healthy Europe. And we do that by supporting spread of knowledge on effective health management, exactly like this webinar is doing right now. And we live our values in everything we do. So you should always expect from us excellent quality, inclusiveness, relevance, and respect. Other things about EMA is that we are uniquely the only membership organization in Europe to bring together the full health management ecosystem. We're a recognized and respected amplifier of best practices in the evolution of health management, and we provide an environment where evidence, challenge, and experience are valued, and complex debates on current topics can take place. So I invite you to join the debate today. If you're not already an EMA member, I'd really encourage you to join. We are the preeminent community of practice on health management, and we'd love to have you an official part of us. So do check us out on our website. So to tell you a little bit more about this series, I mentioned it's episode 5, and the series is Health Management in Action, Fostering Health Systems Resilience. It discusses health management topics that are crucial to improve health systems preparedness and response. So a bit of practical information, you can probably already hear someone's microphone in the background. If you could make sure that your microphones are muted. So do take a moment to check it now, because I can hear a bit of buzzing in the background. And that way we can have clear audio in respect for our speakers. If you've got questions, we really encourage them, and we're here to answer your questions. So type them in the chat box, but also once we get to the Q&A, you can ask the questions live. We record the webinars, and we put all the materials on our website. So usually within the next day or two after the webinar, you can access all that information. And we tweet live. So if you're on Twitter, do make sure that you're following us at EMA Info and contribute with the hashtag EMA Webinars. So let's move on for today's program. You've had my welcome and introduction, and in a moment I will introduce the speakers. We've got a presentation on integrated care approaches to healthcare delivery by Dr. Axel Kaehne. And then we also have a presentation on the role of informal carers in the delivery of care by Mr. Stecy of Yghemonos. And then at the end, we'll have 10 minutes of Q&A. So we hope to give you a good broad understanding around, well, 2 broad perspectives on approaches to care. So let me introduce properly our 2 speakers. I think many of you will know Professor Axel Kaehne. He's been a member of EMA for a long time. He was our president until very recently when his term finished, and he's still part of our board as a vice president now, continuing that great support. Axel, it's really great to have your support of EMA, and especially in your role as Director of Evaluation and Policy Analysis Unit, as a reader in health service research at Edge Hill University, and always more Editor-in-Chief, Journal of Integrated Care. So thank you for bringing all that expertise with us. And also thank you to Mr. Stecy of Yghemonos, who's the Executive Director of Eurocarers, Belgium. It's so nice to connect with you today and to have you joining us. I welcome you both. And I'll hand over directly to you, Axel, if you'd like to get us started.
Thank you so much. Thank you so much for this very, very kind introduction, George. And it's an absolute pleasure to be here, of course, again. And it's also a pleasure to be here with Stecy and my colleague from the Carers Association. So that's really good. It's going to be a nice mix today of sort of like health management and contrasted with the informal carer economy that is supporting and underpinning actually the health services. So I'm going to talk not just about integrated care. I've got a very limited, just about 10-15 minutes. Not about integrated care only, because integrated care is really just one approach amongst others, and the implications of COVID have been far wider than just integrated care. So I'm going to start with a brief look at what actually the health service delivery looked like pre-COVID, and excuse me, of course, please, that many of my comments are relating to the English healthcare system. That's the National Health Services that is in England, simply because that's where I work and that's where I live. But I have a bit of a tiny little insight maybe also into other health services, simply through my research and also through my work in other countries. So pre-COVID health service deliveries, how would you characterize it really? I mean, the landscape was really, I think, in many countries fragmented. It was fragmented service delivery. We've had this since the 70s and 80s. That's no secret and it's no news, especially for people with chronic conditions. So it was difficult to navigate health services for them. They were referred from one to another clinician, et cetera, and these transitions weren't very seamless. We also had largely underfunded social care, if I could only spell. It was social care and community services, causing very often backlog in hospital discharge with patients after treatment. So patients really stayed on in hospital a lot in England. That happened a lot in England, Wales, Scotland, and Northern Ireland. But I'm sure many of these phenomena actually also occurred in other health services in Europe and in other countries. And the problem really is that once the patients are staying on because they can't be discharged, then we have the issue of bed blocking, which is a terrible term. But basically, hospitals can't discharge and they can't actually look after the patient. They can't admit new patients until they have actually discharged other patients. We have workforce shortages. That is a chronic problem for all health services in Europe. And there are also significant inequities and injustices in terms of recruiting health service personnel and professions from other countries, especially from developing countries. The NHS regularly goes to Pakistan and India to recruit health service personnel there. And of course, you just have to think about how they actually invest into their staff, developing them, training them, and then of course they're moving on and migrating to the UK. So there are significant injustices in this instance as well. So the use of healthcare data was just starting, just before the pandemic, just starting to be used more in health service planning and design. So that started with population health data a bit around 2015, 2016 in the NHS. It didn't make a great breakthrough yet, but health service population health data was very much linked with health inequalities as well. So basically they wanted to detect health inequalities by looking at large data sets, population data sets, and asking themselves, how can we actually design and plan health services better in order to address health services in a long time. And of course, we also had diagnostics that started with private, or commercially funded developed diagnostics. Of course, we all have various diagnostics, even around our wrist these days, with the iPhone and the various gadgets we have. Okay, and then the wider system changes. In the UK, it was very much mandated to work together, so social care, community care services, etc. But make no mistake, that was a aspirational language rather than reality. So the fragmentation still really persisted. Now let's look at what happened as COVID emerged. And you would think that many of these problems would be sort of like either being sort of like solved because we had to work better, or they would have been accelerated and exacerbated. What was actually the case is, well, everything was pushed pretty much to a side. So during the pandemic, the health service landscape was radically transformed, but maybe not in the way we wanted it. The fragmentation clearly persisted in some way. Let me just point this out. But we have to remember everything was based on emergency legislation in most countries. So this was an emergency legislation going through Parliament. And there was really a singular objective in that, and that is to provide ICU capacity. So this is the intensive care unit capacity in hospitals. It was a single objective. So all the other things, chronic conditions, etc., were pushed really to the side. And one priority was preeminent. Social and community care, well, in a strange way, during the pandemic, they were almost cut off. They were recipients of patients. They had to take on patients very, very quickly. Some of them transferred with infections, in fact, into care hospital, into community care places. But they were also cut off from hospital care provision. Very often, hospitals didn't even take their patients. They said you have to care for them in the social care unless they really require intensive care. So there was a lot of friction between the services. And of course, in terms of workforce, well, it wasn't really accelerating workforce development. What it was doing, the pandemic, as COVID emerged, is accelerated the ICU training and nursing capacity in certain sections, in certain parts only, and in fact probably worsened some of the shortages in other nursing capacity, as we were drawing nurses and attracting nurses into these particular pathways that were required for ICU nursing. When it comes to healthcare data, well, we did ramp up in England and across Europe, of course, and across the world, the diagnostics and analysis capacity, but it wasn't analysis capacity on population health data or so much, than really just on detecting the infections. So it was relatively limited. And of course, that was also downsized very, very quickly later on, much of that because it was in the commercial sector, funded in the commercial sector funded through public sector monies. And in terms of the system, well, there was access to personal data and there was an early warning system. They were developed and utilized. But don't forget, many of these, and many, as I know it only from Finland and Germany and the UK, many of these were based on emergency legislation that elapsed. So you could, as it were, alert patients and alert people in the community about, pending vaccination services, etc., etc. But you could only do that as long as the emergency legislation was valid. And then once it lapsed, you wouldn't be able to contact them again. So we weren't really creating a lasting legacy there. So post-COVID, you wouldn't be surprised, I'm sure, to see that the legacy of COVID really, people have two perspectives on that. The first perspective is really that the COVID gave us limited learning, really. It was an emergency situation and it was underpinned by emergency legislation. And once that's gone, everything should go back to normal, really. The other one is maybe that the other perspective is that there was significant learning about the power of data, for example, and the resilience in the workforce deployment and the service collaboration. The first perspective is very much focusing on the issue that this was a hospital orientated and hospital focused service. And that just really cemented the predominance of hospital-based services. And there's a whole host of problems with that. And genuine collaboration was rare. In fact, there is now, we now know that this was very, very rare. In fact, the social care and community services suffered very often in this time. But the second perspective, articulates and sees it slightly different. They're saying, well, the use of data will stay with us, and this might give a boost to the population health management. And we have learned something during the pandemic on the adoption of rapid learning cycles. How do we adopt? How do we adapt to new to situations? And then, of course, also increase the resilience of staff. Now, this was pretty much low on data, so I'm just going to give you one little data. You can see probably on this slide here that what we actually now inherited from the pandemic is really a significant crisis in the provision, and these are workforce development crises, really workforce crises. And I just wanted to share with you one thing. Maybe let me just go out of this, and I just wanted to share briefly with you one other data, and I want you to look together with me at a data set that tells us the number of patients spending more than 4 hours from decision to admission. And this is the A&E, accident and emergency admissions in England. And the data goes back, and I hope you can see this now, the data goes back all the way to 2010. So this is August 2010. There were only 3,600 people in England that had waited longer than 4 hours from a decision to admission. And you can see there was one person that waited longer than 12 hours. Now let's go to the pandemic. Just before the pandemic, you can see January 2018, there were already 81,000 people. This was well before the pandemic. So you can see this is actually an endemic problem. This is a chronic problem that has developed over time. And there were 1,000 people already waiting for longer than 12 hours. And you would expect this, of course, to go up during the pandemic, and it did. We hit 100,000 waiting for 4 hours or more in January 2020. But now we would expect this to come down, and come down it did. But look what now happened. This is the summer period. Of course, these things come down, but look now what happened. And we are now well past the pandemic. And we are now at a far higher rate than we were even prior to the pandemic. So 130,000, this is, as it were, normal working pattern in the NHS. And we're now at 130,000 people in August who are waiting more than 4 hours to be admitted to A&E, to be readmitted to the hospital. And look at what happened to those who have to wait longer than 12 hours. 28,000 of them have to wait longer than 12 hours. And I'm not telling you any secrets. Many of them die, of course, on the trial before they even get to the A&E, before they're even being triaged. So this is just a tiny little insight in the complexity of what has changed. It's not that the pandemic has necessarily been the only one that is sort of like made this change occurred, sort of like supported this change. Okay, so there's no going back really, because quite frankly, the pre-pandemic performance of the health system in England was poor on various indicators even before. And the COVID may have exacerbated the situation, but also increased awareness of innovative approaches. And the question really for us is, how do we embed adaptive continuous learning in our health system? Because these are not COVID challenges now. These are normal sort of like operational kind of like challenges for the NHS. Okay, that's pretty much it from my side. If you are interested in the Journal of Integrated Care, you can click on the link. I'm happy to talk about any potential papers or so you want to write. But I also want to just point out 2 publications. You would expect me to use this cheap plug here. There are 2 publications we have recently done. My colleague Henk Nies has published with me, edited a guidebook for managers, how to deliver integrated care. And I published this year also something on integrated care, reflection on change in health service. And you can find this in the links. So thank you very much indeed. And hopefully see you at AMA 2023 as well. We're going to have a conference next year. And George, keep it secret where it is and what happens at this, but I'm sure you will tell us at some point.
Thank you, Axel. That was fascinating. I have a lot of questions. I put my hand up because I have a question which we'll come to after we've heard from Stecy. So if anyone in the audience has questions, feel free to type them into the chat or to put your hand up and we'll come to you. But next I'll hand over to Stecy of Yghemonos. Great to have you with us, Stecy.
Thank you, George, and good afternoon, everyone. I'm delighted to be with you this afternoon for various reasons. The first one being that even though the topic of informal care is becoming more and more prominent on policy agendas, it's only, very rare that we get to actually interact with the health sector, believe it or not. I also have to apologize because I hear from the test before that apparently the sound on my side because of this microphone is not great, so I hope you can hear me. My job this afternoon is really to shed light, I feel, based on the previous presentation, which was really interesting, is really to shed light on the hidden side of the moon, really. It feels like it, at least on the other side of the coin. So what I want to try and do is give you an overview of the situation and needs of informal carers before the pandemic, and also obviously how the pandemic has changed that and where we stand today. So before I start, maybe just to avoid any confusion, a quick point about our definition of informal care, because obviously when we say informal care, it is very clear for us who these people are, but what we find is that some people tend to mix informal carers with domestic care workers or with even care professionals. To us, an informal carer is any person who provides usually unpaid care to someone with a chronic disease, a disability, or any other long-lasting care needs outside of a professional context. Why do we say usually unpaid? Because in some countries, as you may know, or in some regions, it is now possible for informal carers to have access to financial support. That financial support is usually extremely symbolic, so extremely limited, and certainly does not make up for the opportunity loss of the caregiving responsibilities. Now, informal carers are the largest providers of all care really in Europe today. This is based on EU research. According to some estimates, as much as 80% of all care in Europe is actually provided by essentially family members, friends, and neighbors. These are the people we're talking about. But these people are all of us. I mean, we're all concerned. Again, based on EU research, the number of informal carers in Europe today amounts to at least 52 million adults, based on extremely recent data published by the European Commission as part of the EU Care strategy, and that was launched on the 7th of September. So it's very, very fresh. I'll get to that in a second. A typical carer in Europe is a woman, unsurprisingly, between 45 and 75 years old. And so the significance of informal care in the provision of all care in Europe is very clear based on research. Another very striking or convincing argument for decision makers nowadays is obviously relates to the economic value or estimated economic value of this informal care in Europe. Again, based on EU data, that value amounts to between 320 and 368 billion euros per year, which is way higher than the budget dedicated by member states to professional long-term care. In other words, without informal carers, our systems would simply collapse. And if we were to try and replace informal carers by care professionals, we would probably have to more than double the budgets currently allocated to professional long-term care. And as we all know, it's already difficult to maintain the budgets allocated to professional long-term care as is. So in the foreseeable future, it's going to be extremely difficult to maintain access to universal care in Europe without informal carers, and these people need support. When it comes to the impact of caregiving on carers themselves, again, we have a lot of evidence there. First of all, we know that a majority of informal carers actually have a professional life. Many of them actually work full-time, which means that also many informal carers have really to juggle between their professional and caregiving responsibilities. So there's a lot of pressure and there's a lot of stress emerging from that. In terms of poverty and social exclusion, we also know that again, a huge number of carers have to reduce their working hours. So we see a lot of involuntary part-timers. And again, the gender dimension of this phenomenon is very clear. So it's essentially women who are impacted, who have to either reduce their working hours or leave the labor market altogether. Now, obviously, this has an impact on carers' income or financial means. And in addition, many carers tend to contribute financially to the cost of caring, so professional care. Just to illustrate this, to give you an idea, since we were discussing about England, with the previous presentation, in England, 1/3 of informal carers are in debt as a result of their caregiving responsibilities. When it comes to health and well-being, again, a lot of evidence there. We see a lot of negative health outcomes stemming from the caregiving responsibilities, both in terms of mental and physical health. And again, to illustrate, the prevalence of mental health issues, so anxiety, depression, and so on, among non-working carers is 20% higher than among non-carers. So very clear pattern there where if we don't support informal carers, they may very well become patients themselves, and obviously we enter a vicious circle. Now, what about the impact of COVID? Well, as you can imagine, because of the reallocation, understandable reallocation of care services to the most urgent needs, most of the challenges I just listed have been, drastically exacerbated as a result of the pandemic. On our side, we carried out an EU-wide study, a survey across Europe between the end of 2020 and the beginning of 2021, which allowed us to collect a bit less than 3,000 responses from across Europe to assess the impact of the pandemic on the daily life of informal carers. So I'm going to share just a few results of the study, but obviously the whole study or the report is available on our website still. Now, when it comes to the impact of the pandemic on carers' personal and caring circumstances, first of all, it is very clear that there's a very negative impact on the quality of life or perceived quality of life of informal carers, as well as on the mental health and psychological state of mind of informal carers. Now, think about what I was saying before and the risk of carers becoming patients themselves. Very much to our surprise, we expected that respondents would report that they are providing more care as a result of the pandemic and also more intense care as a result of the crisis and the reduced access to support measures and care services. But the new or the surprising result from the study is that a new population of informal carers has emerged from the pandemic. And what's also very interesting in there is that we see more men than usual taking on caregiving responsibilities, which is, I think, is going to be interesting, for the future, because when it comes to the gender dimension, it's going to be interesting to see how this new population of informal carers will, make itself apparent, or at least vocal, maybe in the future. So, an interesting development there. When it comes to the impact on access to support measures and care services, well, first of all, it is important to mention that when you look at the whole of Europe, not all carers have access to support measures or to care services. But among those who do have access to support measures, 1/3 of respondents said that these support measures had decreased as a result of the pandemic. So already the situation was pretty bad before, it's even worse now. When it comes to health professionals, a new also result emerging from this study and from the pandemic to some extent is the fact that the primary care actors played a central role in the provision of support to informal carers during the pandemic. Now, this is completely new, quite frankly. Before the pandemic, we on our side were already promoting the potential role to be played by primary care actors, so general practitioners, pharmacists, nurses, physiotherapists. But the study demonstrates that they have indeed, because of the situation, because of circumstances, these people have been forced to play that role, and this actually could be nurtured and supported in the long run, we believe. Provided obviously that they are equipped and equipped with the tools required to identify and know how to interact with informal carers. Now, when it comes to the action points or how the learnings from our study could be implemented in the future, well, first of all, we believe that there's a lot of room for maneuver to improve what we call the interface between the formal and informal care sector. So this dialogue between informal carers and care professionals could definitely be improved, because on one side, care professionals are usually badly trained in terms of, or even not even aware of the situation and needs of informal carers. And so there are very easy measures that could be put in place to help them in that role, in that information role. Care professionals could also play a central role in the identification of informal carers, which is really badly missing across many member states. We lack mechanisms to identify informal carers in Europe. The role of civil society organizations has been extremely important in the support to informal carers during the pandemic, but I would even say even before and still now. So many of our member organizations, for example, and currently we have 75 member organizations in 25 countries, have found themselves having to provide informal carers with information about the pandemic, with advice, with personal protective equipment. They ended up having to coordinate the dialogue, the relationship with care professionals, and all of this, as usual, with extremely limited resources. And so we should probably pay attention to the role of civil society organizations, and I'm sure the same applies to EMA members to some extent in the future. Now, when it comes to the potential offered by technology, I thought I'd mention it here because usually when we discuss the future of care systems, obviously technology, is always one of the buzzwords. What we discovered as part of our study is that almost 80% of informal carers have never used any kind of ICT-based solutions as part of their caregiving responsibilities. What's more concerning is that only, I think, about 25% of respondents said they would be interested to be supported, in their caregiving with ICT-based solutions, which is concerning because I think what it shows is that there's still a huge digital gap to be bridged if we are to support informal carers based on technology. That certainly technology is not the panacea when it comes to supporting informal carers, and there's still a long way to go. Contrary to what we hear in many discussions, many events, if we are to use technology as a central tool in the future and in the sustainability of future care systems. Finally, there's another new phenomenon emerging from the pandemic. It's the issue of people who provide informal care from sometimes very long distances. So we, for example, were contacted during the pandemic by colleagues from other organizations even who were providing informal care for their parents across the border in the Netherlands, for example, and then suddenly were unable to cross the border anymore, had access to no access to other informal carers. There was no one else in the family who would be able to step in, and therefore found themselves completely, stuck. We even have had cases of people before the pandemic who were telling us that actually a Greek colleague who was telling me that he was traveling almost every weekend back to Athens to take care of his mom who was suffering from dementia. So that gives you an idea of the kind of situations informal carers may find themselves in, and the kind of challenges also they have to address. Now, what's changed since the pandemic? Now, extremely recently, on the 7th of September, the Commission published an EU care strategy, which is great news from our perspective. And the idea there is to say, okay, almost all of the member states face the same challenges in terms of the growing prevalence of age-related and chronic diseases, the same challenge in terms of the growing demand for care, and at the same time, the same quality and sustainability challenges. So it makes sense to work together, not to put in place the exact same solutions, but at least towards the same objectives and using the same values of universal access to long-term care or to care, generally speaking, which is, I think, most welcome. Now, obviously, on our part, as you can imagine, we made sure that the perspective of informal carers would be captured. I won't have time to go into all the details of what the strategy encapsulates, but among the themes addressed by the strategy, and I would encourage all of you, if you haven't done so yet, to have a look at the strategy. The strategy focuses on access, affordability, and quality of care, and long-term care in particular in Europe, adequacy of care systems, so the person-centeredness, the need to focus on the preferences of people and on the human rights of care recipients, but also on their carers. The need to make care professions more attractive by improving the working conditions, by improving salaries, etc. But when it comes to informal carers, the Commission calls on member states to do several things interesting, I think, to this discussion. The first one is to put in place clear mechanisms to identify and support carers by providing them with access to information, training, work-life balance solutions, respite care, healthcare solutions, social protection, so social security, for example, pension rights, and also financial support. The Commission calls on member states to improve the interface, the collaboration between informal carers and care professionals. So it seems that just to some extent, but obviously we were not the only ones pushing, our message was heard by EU institutions. Now, in terms of the next steps, the strategy in principle should be approved by member states during the next EBSCO Council meeting in December, and I would encourage all of you who have a chance to be vocal about this and to make sure your government actually supports the strategy. And then after that, obviously, we will accompany the implementation of the strategy itself. Yeah, I'll stop here for now. I'm sorry if I've been too long, and I'm happy to answer questions. Thank you.
Thanks, Stecy. That was a really interesting presentation as well. We now have two really interesting contributions. In the interest of time, we'll go directly to questions. And I can see a couple have come in into the chat. I'll go first to Danielle Adenisimi. If you would like to switch on your camera, you can ask the question live. Otherwise, we'll just speak to it in text. Danielle, did you want to jump in? Okay, so Axel, you'll see Danielle's question is around the role of technology and what it's poised to play.
Yeah, it's really fascinating, Danielle, and also fascinating before the background of what Stecy just said, the privatization of care, as we are pushing care into the private realm, as it were, because the services can't cope. So it's really interesting. What we do see there, however, is that also private individuals, when they can afford it, are taking up technology. For example, diagnostics, home diagnostics. They simply buy them on the market, take them home, and monitoring their own health. And that's exactly happening as the health services are not picking up that interest, as it were. They're not responding to that interest. So that's the first thing to notice. And to mention here, and that is of course something that's regrettable, because we have publicly funded health services that are now not actually responding to the needs of and demands of individuals. I would hope that technology plays a better role, especially data. We published a paper a couple of years ago on we're looking at the data of who is actually coming to A&E and how can you address this. And the issue was not the data itself. The data is there. The issue is then that the services don't know what to do with this. The services are really struggling to reconfigure in such a way that they're addressing the actual health needs of it. Just to give you a tiny little snippet in one sentence, the people who turn up at A&E most often per night are those with chronic mental health problems or with alcohol problems. They can turn up at about 20 times a night, clogging the system, of course, because anytime they walk through the door, they need to be triaged by a nurse, by law, and by obligation. And then, of course, they're walking out again, and they're coming back in again. So you can see this, how this problem perpetuates, of course. So Dania, of course, it's difficult to learn from other countries because these are so very specific, but it is absolutely important that not just the data is there, and the technology is also pushing itself onto the system, but the question is, are the services ready to take up that offer? Are they actually adaptable enough? And can they work with these new innovative solutions? And that's where we and EMA, of course, are coming in, because that's a health management issue, not a learning issue, and not a technology issue as such. I hope that makes sense, Daniel.
So I've got a few provocations. So one of them is, if we were to take that cohort of people who might have a problem with alcohol misuse and remove them from all the statistics, would that solve the problem, or is that just one example?
Good point. Absolutely, yeah. No, it doesn't solve the problem, of course. I mean, I'm picking here on a very unfortunate population that is sort of like the what we call the cherry, the low-hanging fruit, as it were. Yeah. But you're absolutely right. The issue that I flagged up earlier about A&E waiting times, and you asked me where we have been pre-pandemic. We've been the fourth worst. Even in Europe, even before the pandemic, in terms of waiting times for A&E. But the issue is really that this is a very complex issue. It's the emergency trusts, the vehicles lining up, as well as the hospital services that can't admit them, as it were. So you have actually two services not working together. And of course, what happens is, as Stecy said, you let people stay at home to a certain extent, even though they should be attended to by a health professional. So you're absolutely right, George. It's a very much far wider problem.
Axel, I want to come back to you with a couple of other questions, but just on this theme of technology, Stecy, you mentioned as well that there's opportunities for better uses of digital innovations in caring. Is there something more you could say to that? Like, is there an example?
Absolutely. We have plenty of examples of good practices in that regard. What we've, discovered is, when it comes to the use of technology, it can be extremely useful to help informal carers in terms of their access to, first of all, information and training. Many informal carers become carers overnight, pretty much overnight. It is extremely difficult for many of them to have access to information from the care professionals, who sometimes have no time or simply refuse, let's face it, to share information with informal carers. And so there's a lot of ICT-based solutions for them to access information and training to also improve the quality of the care they provide. A lot of ICT-based solutions also to help informal carers with care coordination. So to interact with care professionals, say, a nurse comes every day or every week to leave notes to say, oh, I visited my dad last night, he didn't feel well, and so the nurse can actually check and, take over. Things like that. In terms of simply allowing them to monitor the situation from, remotely, and therefore to maintain an active social and professional life. So you're at work, and then from time to time on your smartphone you're able to check whether your mom is okay. Things like that. So there are plenty of good examples, but I must confess, most of them are unfortunately driven by the supply side rather than the demand side. And so what we lack at the moment is really some sort of a systemic approach to these issues. So the market generates a lot of good ideas, but they're not necessarily connected to the bigger picture of how the system is structured and how informal carers are connected to it.
Okay, thank you. Axel, I'll come back to you around some of the comparisons. I mean, you've talked about how England has compared to countries in the rest of Europe, but I wonder, what can we learn from these comparisons? Like, when we talk about England being the fourth worst for some measures, but really, is there a great variance? Like, are there countries we should be looking to, or are countries comparatively essentially having a similar problem, and there will inevitably be someone who's the best and the worst, but all told,
Yeah, that's a really interesting point with that, because that really highlights what are the data that we collect and which data are we making public. Now, the OECD have a fantastic data set. If you ever wanted to check out comparative figures, go to the OECD website really, and they're collecting data as they are being provided by the countries. Now, you will see there are actually gaps in the data, because where they have developed comparative indicators for health conditions, some countries just simply don't provide those figures. So, some countries don't want to be measured on some of these indicators, and that's their way of saying, okay, well, this may not be a priority for us. But in terms of learning, I think what's important is that basically what I tried to say earlier, the worker resilience, the burnout, these sort of like issues that are happening, these health management issues are occurring across Europe, and in fact probably across the world, and not just in developed countries. And that's where we can learn, because we are developing very often solutions in parallel, and then we're learning from each other later on. And we should be able to look over each other's shoulder and learn much more from each other. One thing I just want to do, just a post note on what Stecy just said. One of the things we notice as well is that the healthcare and the informal care ratio is very often also linked in with deprivation issues, socioeconomic deprivation and others. And what we do find is one particular problem, for example, is children becoming carers for their families, or for their parents, or for their relatives. And that we know that is particularly the case in some of the economically deprived areas in England. So in fact, we have the data. We could even identify families that have that issue and preventatively kind of like address that. But we really have to make better use of the data, and we have to then think about how our services can address this. How can they reconfigure? You have to literally move staff from one corner to another corner of the service, and you have to upskill them. And that is a huge challenge for everybody. And it's a change problem as well. No one likes change, least of all when we are in professional services where services are linked to professional guidances, etc. So hope that makes sense, George.
Yeah, absolutely makes sense. And actually what it has me thinking from both you and Stecy is there is so much more to talk about. And there's a temptation now, I want to say, let's just keep talking for another hour, because there's so much more to say. But that's the purpose of this webinar series. So as you know, this is episode 5 in a total of 10. So these conversations are long-term. We need to keep talking, because we're talking about big shifts in our thinking. So I'd invite you all to come to our next one as well. We shape these webinars from you, from our members and from people attending. So there's a 90-second survey. There's a link for it in the bio. In the notes, it really takes 90 seconds. Let us know what might be outstanding from this. There's a lot of questions we couldn't get to. Sorry to Evelyn, we couldn't get to all of your questions. So you can speak to your questions in that survey. You can put down a dot point about what you'd like us to talk about in a following webinar, and we'll certainly pick that up. Like I said, all of these things will be published on our website. And if you want to stay in this conversation about reforming the health system, then come to our next webinar. Get it in your diary now, Tuesday the 18th of October, the same time. We make them bite-sized so they're easy to digest. And we've got Professor Dr. Walter Sermus joining us next week from KU Leuven, looking at improving mental health and well-being. So clearly building on today's conversation. Axel and Stecy, really thank you so much for coming and sharing your expertise and your learning with us. And we look forward to staying in touch with you and sharing more as we go forward.
Pleasure. Thank you so much.
Thank you. Have a great afternoon.
Thanks. Goodbye.
Bye-bye.